Hi, thank you so much for joining me. I'm going to give you an overview of my internship deliverable, which was a blog post about the need to engage specialists in payment reform. This summer, I worked on 2 projects about this topic, and I'm really excited to share what I've learned with you. But first off, I'd like to ask or get you to think about what percentage of healthcare spending that you think is on specialist care. As a bit of a hint, think about how much spending might go towards specialties like cardiology, orthopedics, and cancer care, things that tend to be more on the expensive side. Feel free to pause the video and think about your guess. The short answer is it's a lot. There's a lot going on in this graphic, but what you need to know is that the yellow is primary care, everything else is specialty care. You've got office-based physician visits on the left and expenditures on the right. Overall, specialty care makes up about 70% of expenditures. This data is actually from 2009 and is across the entire health system, but it's been trending higher, so it could be even greater than 70% at this point in time. So even though specialist care makes up such a large proportion of spending, participation in value-based payment reform is much higher among primary care physicians. The exception is among payment models that are specific to one specialty. For example, models that focus on chemotherapy for patients with cancer and on care for patients with end-stage kidney disease. So a key question in the field of payment reform right now is how to get specialists to participate in voluntary value-based payment models. But to start with, there are some different factors to consider when thinking about ways to engage specialists. So things like the type of accountable care organization, whether it's hospital-led or physician-led, the type of payer, so whether that's Medicare, Medicaid, or commercial, the relationship of the specialist to the ACO, whether they're in the network or out of it, and the relationship to other providers, so primary care, whether they're working with other specialists. And since there are so many factors to consider, there's no one-size-fits-all approach. So in my blog post, I wrote about 2 potential approaches to start with. One option is to focus on engaging specialists that have the highest volume conditions, that have the largest impact on morbidity and mortality. So some examples might be specialists working on cardiovascular disease and common types of cancer. Another option is to start by focusing on specialists that tend to involve more low-value care. So that's care that maybe is unnecessary. You kind of do it just for the sake of it, and is a little bit wasteful. An example is surgeries for degenerative joint disease. Not all of them are low value or wasteful, but there are some statistics that a lot of these surgeries maybe don't need to happen. No matter what the approach is, there should be a specific focus on advancing health equity. Accountable care organizations have historically excluded underserved populations by taking a rising tide lifts all boats approach, which is just, and improving quality all around will have care improvements for everybody, but that isn't the case, and this approach can actually deepen inequities rather than decrease them. The new CMS, CMMI models have a specific focus on enhancing health equity, such as the upcoming ACO REACH and enhancing oncology care models. These models have a couple of strategies that are specifically focused on health equity, like the development of a health equity plan and socio-demographic data reporting. And so strategies to engage specialists might include some similar health equity safeguards as these new models. Some key takeaways: specialty care accounts for a large proportion of spending, but engagement in value-based payment is pretty low among specialists. Initial strategies might target high volume conditions or low value care, and regardless of the strategy, we must consider the health equity impacts and avoid widening disparities. A couple of acknowledgements. Thank you, Jonathan, for your mentorship throughout the summer and the feedback on initial drafts. and the rest of the specialist engagement project team whose work helped inform the blog post. Thank you so much for listening.